Very good evening from Ortho TV on cardiac health. I request our secretary Madhusudan sir to start the program. Madhusudan sir, please.
Thank you, Dr. Shamsul. Shamsul, am I audible?
Yes, sir. Perfect, sir.
Am I audible?
Yes, sir. Loud and clear, sir.
Thank you, Dr. Shamsul. Respected President BOA, Dr. Ejection Fraction, sir, our speaker, Praveen Sinha, sir, our moderator, all the panelists, BOA members, audience, and Ortho TV, especially the convener of BOA, Dr. Shamsul Hoda. And today's topic is very important and very one of the best topic, cardiac health for the doctor. We all doctors facing a lot of stress and strain. So this topic is very important, and we are very lucky. Our speaker, one of the renowned cardiologists of Bihar, Dr. Preoperative Evaluation, sir, and his DM in cardiology. I wish you all, this is very beneficial for all the members of the BOA and audience. So I wish you all for the grand success of this program. And I request Dr. S.N. Saraf, sir, our respected president, to say a few words.
Hello, good evening. Am I audible?
Yes.
Good evening to you all. On behalf of Bihar Orthopaedic Association, I welcome Dr. Preoperative Sinha, cardiologist. He's the first DM cardiologist of my town, and his rotation is very popular. I welcome our panelists, Praveen Jha, as well as PN Misra ji, and our IT cell convener, Dr. Shamsul Hoda. We have many questions to ask. Many of our colleagues are suffering from cardiac anxiety. Dr. Sinha will enlighten us about healthy heart and tips of the healthy heart. Thank you. Now I hand over to our moderator.
Thank you, sir. It's such a pleasure that we have with us the renowned cardiologist of Bihar, Dr. Preoperative Sinha, sir. And as we all know that lot of orthopedic surgeons, they always stay in stress, stress for the surgery. Many of them have suffered from COVID, and they have lot of anxiety issues, lot of palpitation issues. So today we have with us Dr. Preoperative Sinha, sir, and he will be sharing his slides with us, and he will be talking on cardiac health for the doctors, focusing on the doctors. So now I invite our cardiologist, sir, Dr. Preoperative Sinha, sir, to start his presentation.
Thank you, Dr. Abhishek. Thank you, Dr. Saraf, President, Bihar Orthopaedic Association. I also convey my thanks to Dr. Madhusudan, the secretary, and Dr. Shamsul Hoda, who is the IT cell convener, for giving me the opportunity to present my views on this very important topic in this gathering of orthopedic surgeons and other specialties. First, I must congratulate our orthopedic surgeon colleagues who have done tremendous advances in the field of orthopedics, that the management of orthopedic diseases has changed in the last 25 years. And we are really proud of our orthopedic colleagues. I will also definitely praise Bihar Orthopaedic Association, Indian Orthopaedic Association, about the fact that they are celebrating this Bone and Joint Week, and they are taking up issues which are very relevant to the public and to the doctors specifically, not strictly related to medicine, but otherwise also. Yesterday, I watched the program on education, and it was so informative. So that's, kudos to you. You have, you are thinking much forward than many other people, and that must be praised. Now, as far as today's topic is concerned, I'll start sharing my slides. I hope all of you can see the slides.
Yeah. We can see, sir. We can see.
Cardiac health for doctors is a very important topic for all of us. Today's discussion I have divided into 3 parts. Basically, in the first part, I will discuss a bit about the basic cardiac structure and function, pathology, diagnostics, and therapeutics, including preoperative cardiac assessment. Of course, many things can't be dealt with in detail in a short time, but we'll try to make it simpler so that doctors from other specialties can also understand it. And of course, as we all know, cardiologists and orthopedic surgeons also know that there is a relationship between orthopedic and cardiological sciences. And I will dwell for a few minutes on this interesting topic also. In the second part, I will discuss the prevention of heart disease. And finally, I will try to present some points about maintenance of cardiac fitness for doctors and their families. The basic cardiac anatomy, we all know, most of us are aware of the fact that heart is a 4-chambered structure, right atrium, right ventricle, left atrium, and left ventricle. The deoxygenated blood goes from right atrium across the mitral valve into the right ventricle, and then through the pulmonary artery into the lungs for oxygenation. And then through the pulmonary veins, it comes to the left atrium, across the mitral valve into the left ventricle, and then it's pumped into the aorta by the muscular left ventricle to all parts of the body. In this picture, we can see the 2 major coronary arterial trunks. There are 2 major coronary arteries, left coronary and right coronary. The left has got 2 major branches, anterior descending branch and the left circumflex branch. And this is the right coronary artery. Heart is a muscular structure. The left ventricle is much thick-walled than the right ventricle. And of course, this has implications in many diseases and in particular on the ECG also. How does heart contract? Basically, the cardiac contraction is related to the electrical activity going inside the heart. The electrical activity, how does it go? This is a simplified diagram of the cardiac conduction tissue. The impulse, the electrical impulse arises in the SA node, sinoauricular node, and it travels across the atria, and then it also travels to the AV node and the bundle of his, which is situated in the top of the interventricular septum. Now this bundle of his divides into 2 branches, right and left, and it distributed through the Purkinje fibers in both the ventricles. This is through these conductive tissue, cardiac impulse travels, and then the muscular contraction of the heart occurs because of that. This is again an animated diagram showing the cardiac physiology. The deoxygenated blood in blue coming through the vena cava into the right atrium, across the tricuspid valve into the right ventricle, and then getting pumped into the pulmonary artery. And then after oxygenation in the lungs, it comes through into the left atrium, across the mitral valve and into the left ventricle. And then it's pumped into the aorta so that it's supplied to all parts of the body. Cardiac diseases are innumerable. This is not a comprehensive list of heart diseases, but we can name a few diseases which are common and which we should know about. At least people of doctors of all specialty must know a little about it. Coronary artery disease is a very common disease, and it can be an acute disease or a chronic disease. In acute disease, it can be acute coronary syndrome, like unstable angina or acute myocardial infarction. In chronic disease, it can be a stable angina. Valvular diseases can be rheumatic heart disease or related to it, or non-rheumatic valvular disease like mitral stenosis, regurgitation, aortic stenosis, and aortic regurgitation. Again, this rheumatic valvular disease is of many times common interest to to orthopedic surgeons and cardiologists, because many of the cases of rheumatic heart disease, particularly younger people, present with joint pains, and they often consult the orthopedic surgeon first. Then the hypertensive heart disease, which is increasingly becoming common. Arrhythmias and blocks are an important category of heart disease, such as atrial fibrillation, complete heart block, and cardiomyopathies, such as a dilated cardiomyopathy and many others. At this point, I would like to spend a few lines, speak a few lines on the value of ASO titer in rheumatic diseases. Now, ASO titer is a very important investigation which helps us in the diagnosis of rheumatic heart disease. But often we fall in a so-called trap. The patient comes to us, we get an ASO titer done, ASO titer is raised, and we think the patient is suffering from rheumatic fever. It's not always the case. Raised ASO is basically a response to streptococcal, a specific type of streptococcal infection. So even a sore throat due to that streptococcal infection can increase the ASO titer. So we must not always think that whenever ASO titer is raised, the patient is suffering from rheumatic fever. There are certain criteria. If they are also present along with raised ASO titer, that then there is a strong possibility that rheumatic fever is present. Now, what are the common symptoms of heart disease? Chest pain, as we all know that chest pain in acute coronary syndrome, the chest pain is very severe at rest, radiates to upper limbs and jaws associated with sweating. But in chronic stable angina, the chest pain only occurs when the patient makes an effort, walks or climbs stairs or do some heavy work. Then presence of edema or dyspnea on exertion and orthopnea. They are important signs of heart disease. When the patient sometimes suddenly wakes up at night with severe dyspnea and he can't lie flat. So that's an important pointer towards presence of heart disease. Other symptoms can be palpitation, giddiness, and syncope. Now, how do we do a basic clinical evaluation and diagnostic workup in a patient of heart disease? I will be very brief in these and try to make it as simple as possible. Thorough history and physical examination is very important. Taking a proper history is an important thing to the maximum extent in cardiology. I think no other specialty it is that important as in cardiology, because a careful history tells you almost in 75% of the cases tells you the diagnosis, and even if it rest of the 25 cases it doesn't tell you the diagnosis, it points towards the pathway you should take to establish the diagnosis. So careful history taking is definitely very important along with the physical examination. BP should be taken, and of course the basic cardiological point of view investigation are blood glucose and measurement of a lipid profile. The basic diagnostic further work consists of getting an ECG done. We all see ECGs, but the point to understand and realize is that ECG is an investigation which has very low sensitivity except in acute situations like acute myocardial infarction or arrhythmias. If the patient is not suffering from an acute cardiac disease, in 99.99% of the times, the ECG will be normal. So a normal ECG does not rule out heart disease. A patient may be suffering from a very severe form of heart disease, even with an absolutely normal ECG. So the time-honored teaching that the ECG should be interpreted in the light of clinical situation is very important. So if the patient comes with a normal ECG, it doesn't mean that the patient doesn't have heart disease. In that respect, of course, a proper history again guides you further. A basic ECG, if you want to understand the mechanism, the complexes and intervals, ECG has got ECG trace has got a P wave and a QRS complex and a T wave. This is a graph, and each small square measures 1 millimeter in this direction and in this direction. So the next investigation which we usually do to establish the cardiological diagnosis or do the and to see the cardiac condition is an echo. In echo is basically it shows the morphology, fusion, pericardial effusion. You can see the valves, its conditions, and the contractility of the heart, or wall motion abnormalities, which part as compared to the other or not. So these are a very important investigation which shows you the morphology of the heart, and the basic normal heart looks like this in an echo. This is the left atrium, this is the left ventricle, this is the right atrium, and this is the right ventricle. This is the interventricular septum. Now, one very interesting point is the ejection fraction. Most of the surgeons, and I think most of the anesthetists rely quite a lot on the thing called ejection fraction. Now, we must understand a few things about ejection fraction. We asking, what is the ejection fraction? Is it below 50 or above 50? If it's below 50, something is wrong. If it's above 50, then everything is okay. It's not that simple. Now, what is ejection fraction? Ejection fraction is basically a measure of the cardiac contractility. It's expressed as left ventricular stroke volume. Stroke volume is the blood pumped in one beat divided by end diastolic volume, that is the blood received in previous beat, multiplied by 100. So how much part of beat, that is the ejection fraction, how much blood has been ejected. So on an average, normal ejection fraction is 50%, there's no doubt about that. But is it the point only on which we should rely to decide about the condition of the patient and to decide about the fitness for surgery? No, because there are a large number of conditions in which the patient can have an ejection fraction above 50%, maybe 70% and 80%, and the patient is suffering from a severe type of heart disease. Say a patient with severe atherosclerotic triple vessel disease, all three arteries blocked. Patient having severe angina, and his ejection fraction, we do an echo, and ejection fraction is 70%, 80%. That doesn't mean that the patient is a low risk patient. It's a very high times we see patients who have an ejection fraction of say 40%. It does not always mean that the patient is a very high risk in the very high risk category for surgery. No, it's not that. If a patient who started with congestive heart failure has undergone medical treatment, he had ejection fraction of 20%, 30%. Now with treatment, ejection fraction has improved to 40%. Now, if we assess him, and if we assess that he can climb 2 flights of stairs and without any symptoms, even if his ejection fraction is 40%, he is a very low risk patient for surgery. So ejection fraction, it's okay that 50% is a cutoff margin, but it's not, and everything below 50% is always bad. So we have to assess the patient clinically, how serious his heart is, how serious his cardiac condition is, so that he's assessed properly for surgery. Other investigations which we usually do in heart disease are treadmill tests. We all know about for conditions which arrhythmias which occur infrequently. We do a 24 hours ECG analysis. That's the Holter monitoring and stress echo. One investigation which has recently come up in the last 10 years and so more modernized in the last 5 years is the CT coronary investigation test, in which you put in the angiogram of the coronary arteries, and there you can see if there are atherosclerotic obstructions in the arteries. And even you can do a 3D reconstruction of the heart and the coronary, and the patient has to undergo a surgery, any type of surgery, orthopedic surgery, or any other type of surgery. And we do a CT angio and his coronaries are normal, then he definitely becomes the low risk patient for surgery, and he can be safely undertaken for surgery. And finally, this is the conventional invasive angiogram, in which we inject a dye in the coronary arteries to directly visualize the coronary arteries and see whether there is any atherosclerotic obstruction. And this test is, the technology of this test is somewhat related to what orthopedic surgeons use. I think you always use the C-arm in your labs. I hope you can hear me.
Yeah. Now you begin. There is, I think, some net issues or like some, your voice is not so clear. Now I can hear you very loud and clear, but like before, like 5 minutes back, it was not so clear. You can continue on, sir. You can continue. Okay.
And then surgery consists of coronary artery bypass grafting, in which we bypass the coronary arteries with arteries harvested from other side and bypass the obstruction. And of course, valve replacements and pacemaker implantations are other types of surgeries. Now, what about the preoperative evaluation? Because often anesthetists and surgeons, so that and they have to decide whether they are low risk patients for surgery or high risk, so that they can take up them for surgery, or even if they are high risk, they can take precautions. Also, the detailed preoperative evaluation criteria, we can't discuss here, but in detail. But of course, there are certain points which I wanted to emphasize, are that mild rise of BP does not increase the surgical risk. If a patient has got very mild, the BP is 145/95, So it's not a high risk patient. So we should not worry about that. Of course, if we find a patient with a blood pressure of 200 by 110, then definitely the blood pressure should be controlled before surgery takes place. Second thing is a resting ECG is mostly normal and very insensitive. As I said previously, it's very insensitive to detect heart disease. So a simple normal ECG does not mean always that the patient's heart is normal, and he or she has to be evaluated further. Then again, often we find occasional ectopics, ventricular ectopics or supraventricular ectopics on the ECG, but occasional ectopics are not to be worried about. They occur in almost all normal people, so and they do not increase it. And the ejection fraction, as I discussed previously, should be evaluated according to the patient's other findings, not in
I'm sorry to
isolation.
interrupt, sir. I'm sorry to interrupt, sir. Like, can you try
One
switching?
interesting thing I wanted to discuss at this point was, yeah, Abhishek.
Yes, sir. Can you switch off your video because your voice is, like breaking a lot.
Just a second.
I mean, such a interesting topic, but there is some breakage in the voice.
Let me see. I've stopped my video.
Yeah.
Let me see. Okay, let's see.
Please carry on, sir.
So this was an interesting thing which I could find was the link between osteoporosis and cardiovascular disease, or the further implications of osteoporosis, mainly by the orthopedic surgeons. But there has been a recent interest in the link between osteoporosis and heart disease. It has been associated with increased cardiovascular mortality, morbidity, and atherosclerosis. Calcification and other substances found in the atherosclerotic plaques, which usually cause the obstruction in coronary arteries, have almost the similar composition as that found in bones. And it's thought that shared risk factors, a common risk factor between osteoporosis and cardiovascular disease, some common pathophysiological mechanism and genetic factors could be the reason behind this link between osteoporosis and heart disease. But as you always use vitamin D and calcium supplementation for osteoporosis, unfortunately, it has yet not shown significant benefit in atherosclerotic cardiovascular disease, though many cardiac drug preparations are coming, which combine vitamin D with those cardiac drugs, but as yet there is no proof that they help in atherosclerotic cardiovascular disease. But of course, we must know that maintenance of optimal bone mineral density can be important for cardiovascular health also. Now, what about prevention of heart disease? Prevention of heart disease can be dealt in three ways. Number one is awareness about preventive evaluation, lifestyle modification, and care of the morbidities present. Preventive evaluation consists of at least can you hear me, Abhishek?
Yes, very clearly, sir. Very clearly.
Yeah,
Now it's much better.
Okay. Thank you. Thank you. So preventive evaluation consists of at least yearly thorough physical examination, which should consist of clinical examination, including measurement of BP, hemoglobin, blood glucose, creatinine, and lipid levels. ECG is usually done part of the routine yearly physical examination, but as I said previously, it's a very insensitive thing. There's no harm in doing an ECG, but in most of the normal people, it won't show any abnormality. Again, a treadmill test, stress test is sometimes useful, but it has got lots of fallacies also, and only in particular group of people, stress test for detection of heart disease, for detection of atherosclerotic heart disease can be useful. The BP level should be, normal BP level should be less than 140 by 90 millimeter mercury in an average, in an average person with no significant other risk factors. And when we do a lipid profile, the LDL cholesterol, which is the most important part of the lipid profile as far as atherosclerotic disease is concerned, the LDL cholesterol should be less than 130. Of course, those who suffer from some sort of heart disease, this level is still higher, and LDL cholesterol should be reduced further. This level is for people who don't suffer from many types of heart disease. And the triglyceride should be less than 200 milligram per deciliter. Lifestyle changes consist of physical exercise, at least a moderate intensity exercise, walking on the driveway, on a road, or in a field, or on a treadmill, but a moderate intensity exercise at least 30 minutes per day. Of course, those who are younger, who don't have any physical problems, and they can sustain even a 20 minutes exercise. Healthy diet, this is the concepts have changed quite a bit, and they keep on changing from year to year in many ways. But in general, what the current thought is and the current recommendations are that a vegetarian diet, or those who are non-vegetarian, in them a Mediterranean type of diet, which is mainly a fish-based diet, and a low-calorie milk-based diet. These are the best types of diet which help in prevention of atherosclerotic. Vegetarian food for them, lean meat like chicken, or food with less of saturated fat, plenty of fruit, dry fruits. These are should be the very important constituents of an average diet. Salt intake should be kept below 2.3 grams sodium per day. This comes to about 1 level teaspoonful of table salt. We should use less than this in whatever we eat in the 24 hours time. And we must also mind the presence of hidden sodium in many junk and processed and fast food snacks, which always are, which increase your cardiovascular disease. Again, alcohol, consumption of alcohol. Of course, ours is a dry state, but in general, if we talk about consumption of alcohol, moderate dose, of course, outside Bihar, if they take alcohol, they should take result in aggravation or production of some new arrhythmic heart disease. So a moderate alcohol intake is supposed to do much. Smoking and tobacco, we all know, is nothing to specify about it, is a strict no-no, which is a high risk behavior for development of heart disease. Hypertension, diabetes, obesity, this should be controlled by appropriate means, whether by lifestyle modification, drugs, or devices, or stents and balloons, and they should be appropriately controlled. Relaxation is a very important part of prevention of heart disease. Relaxation can be brought about by modifying your work schedule, by taking of yogas or relaxation exercises. These and taking things easy, these all help in relaxation, and they definitely help in reducing the chances of development of heart disease. Now, some added points for these points are also applicable for doctors, but some added points for cardiac fitness for doctors and their social and professional well-being. Medical problems in doctors can occur as commonly. So, I mean, there is no separate management for a specific type of heart disease in the doctors. They have the same health issues, but there are certain problems that the doctors many times feel that they are invulnerable, that they can't develop a disease. And they feel that since they have been dealing through years with the patients, they feel all powerful. They have a feeling at the back of the mind that they are not vulnerable, they can't develop the disease, but that's not true. Doctors are also human beings, and they also develop the same types of diseases. So we should accept that we are also susceptible to developing a disease and do some preventive aspects. Sometimes we are embarrassed to consult our colleagues. And that is one of the reasons many people ignore their health issues for long. And when they consult the colleagues, it may be the disease. Then additional issues such as professional, legal, patient care, family, financial, these are also produce stress and strain and promote the development of many types of disease. Of course, COVID is a new thing over the last 1.5 years, which has aggravated these problems. Doctors have become more susceptible actually, and due to related patient management issues and pressure from the government and from the setup in which they are working, it has aggravated their problems, and many of the doctors have suffered from disease, either from COVID directly or from the related effects of COVID. It's a well-known fact that doctors often care more for the patient than themselves. I mean, they may wash their hands because they think that the patients can be harmed if they do not wash their hands. But they don't think that even they can be harmed if they don't wash their hands properly, or their families can be harmed. There was one study about 10 years back. This is a very famous online which studied in USA. These data, of course, relate to USA, but we can extrapolate it to our country also, that how happy are the physicians. And the happiest ones were the rheumatologists and dermatologists, neurologists. Luckily, we cardiologists and orthopedic surgeons are somewhere in between. So that's at least a plus point for us. There's again a similarity between orthopedics and cardiology. And how do physicians rate their own physical health? Again, luckily, cardiologists and orthopedic surgeons are on the top of the line. Of course, not the topmost again, dermatologists. But most of the time it was seen that these specialties were in better state of health than others. But as far as weight was concerned, in general, doctors, almost 1/3 of the doctors have got they are overweight, and probably they don't take care of their cardiovascular fitness, and as a result in overweight. And exercise also done almost almost 1/3 of the doctors, they do very poorly if you consider how frequently they exercise. So these are important findings, and these results show that we often don't take care of our health properly, and we should also think about this in a proper way. So what is the way out for doctors for maintenance of good health? We should change our attitude towards life, patients and colleagues and family. It's not that simple, easier said than done. Care has to continue lifelong, but we should take care of us also, and we shouldn't worry excessively more into it, because the patients are at risk even after surgery for some time, and sometimes peer pressure from colleagues and family also affects our life. So we should make a balance between these. We should follow the preventive aspects of the cardiovascular disease. We should take a break, at least maybe a short break every 4-5 months, and long break maybe every 10 months or a year. Indulge in some sort of relaxation, social service, and your stress. I personally is also a very active member, and Dr. Abhishek, we always feel that doing a social service, however small it may be, it helps in reducing their stress, and it increases your general fitness and cardiovascular fitness also. And don't forget to get a medical insurance for the whole family. No, everybody can fall ill at any time, and in this COVID time, it is another point which we can, which this issue can't be overemphasized. And don't ever hesitate to consult a colleagues. That we are also human beings. We can be affected by any disease, and there is no harm in consulting a colleague. If we think of that, we suspect that we are suffering from a disease. Finally, family is an asset, and no time spent elsewhere can be superior to it. No patient, no clinic, no nursing home, no medical faculty is superior to family. And this one point that the time spent with our family, it gives you much more pleasure, is very proper. Then medical organizations like Indian Medical Association or the Orthopaedic Association and Cardiac Society of India can help doctors in their maintaining their fitness by organizing health awareness and starting insurance schemes, which gives confidence to doctors and their families so that they can maintain their health. And these are the ways in which I think we doctors can maintain our general fitness and specifically cardiovascular fitness, so that we are able to serve the society and the people in general as long as possible. Thank you so much for a patient hearing.
Thank you so much, Praveen sir. Indeed, a great talk, and we learned many things. From patient point of view also we learned many things, and from like our point of view also we learned many things. Rightly you said that like attitude of our lifestyle should and need to be changed. I mean, we should have balanced life. First of all, you talked about the preventive measures, which is very important and essential nowadays. I mean, there is no doubt about it. You told that we need to take a break. I mean, yesterday only I was listening to one of my guide, and he always tell me that like between two surgeries also plan like 5 or 10 minutes kind of break. Try to enjoy that moment, because it's not the surgery which will give you pressure. The time lag between that will like irritate you and will keep you burdened. So always try to take a micro break. According to you also, it's very, very useful. You have always been a source of inspiration for us. You have been associated with many social services, especially Rotary. You are at very high rank in Rotary Club also, and you have always been encouraging everyone in Darbhanga, including me, to like serve people. And definitely it gives a sense of satisfaction to all of us. That is also very important. Like at least it gives you some self-respect, as well as like sense of completeness. You rightly told that like this is high time that every doctor thinks about everything, but they never bothered about themselves. I mean, they are so, I mean, I know many of them that like they have not been covered by medical insurance. Many of our colleagues in our association also, I mean, they were not covered by medical insurance. And when COVID happened, many of them had many financial issues also. So, I mean, medical insurance is a way ahead. There is no doubt everybody should get it covered, at least all the medical, like fraternities people, because they are at high risk in like in comparison to the ordinary people. So all these things are very important. You talked everything very rightly. Now I like if anybody wants to ask any question, I mean if anybody wants to ask any, I can see Dr. Praveen Jha sir also there, like he's my senior from
Good evening, Abhishek.
Good evening, good evening. Good to see you, sir, after a long time. Papa, you want to ask anything?
No, it is quite clear from Praveenji's side. The talk was very elaborate and informative. As a surgeon, I was scared of finding of ECG and echo finding. Now I am quite confident that I can go ahead with ECG finding and echo finding. Clinical assessment is more important than echo and ECG. It is now quite clear to me. As a surgeon, I appreciate this. Thank you, Praveenji, for nice talk.
One thing I can also say, as an orthopedic surgeon, ECG is kind of, like we don't understand ECG very well. One thing we see is ejection fraction, and today I get to know that like many times it happens that like even if your ejection fraction is low, even if your ejection fraction is on the side, then also, I mean, we can like take up such kind of cases for surgery. So that's very informative. Many times we cancel such kind of cases, and many times like we are scared to do such kind of cases. So thank you for everything. So one thing I wanted to ask, that like post-COVID cardiac related issues are now very common in medical fraternity. I mean, they suffer kind of lack of sleep, anxiety disorders and all. So, I mean, do you have, I mean, first I will start with, in fact, Praveen Jha sir, like both of them are cardiologists. So like post-COVID cardiac issues are quite common, and many of our colleagues have, like anxiety issues, lack of sleep, palpitation issues. Any specific measures for such kind of people you want to, like? I'll start with Praveen Jha sir.
Good evening, Praveen sir.
Good evening.
The most important thing you already discussed, that ejection fraction. So I get a number of calls that ejection fraction is less, so we should go for the surgery or not. So as you rightly said, that it's the symptom, or to be precise, the functional capacity of the patient that decides the preoperative precautions to be taken. And Abhishek, in this COVID area, COVID, actually it is you can say it is a pre-thrombotic state. And the COVID already, you know that there is a high titer of D-dimer. So there is increased risk of thrombosis in COVID patients. So we should always keep this in mind. And the most of the patients that come in the after COVID are due to palpitation. So there are some reasons of palpitation. One is the anxiety, and other is that some patients develop dilated cardiomyopathy or myocarditis in this post-COVID. So we should do an echo of these patients to rule out whether the COVID has affected the heart. And second, the precaution as such, there is no breathing exercise is the most important, because when your lung function is okay, then your tachycardia and other things will settle automatically. But if a patient has affected with COVID, then we should do D-dimer. And if the D-dimer is in the higher side, then use of anticoagulants is necessary.
All right. Perfect, sir. Sir, Praveer sir, can you hear me, sir?
Yeah.
So,
right.
any your recommendation, sir, for such kind of cases? Does yoga or any lifestyle changes work in such kind of cases? I mean,
I agree with Dr. Praveen that most of the patients, except for those who have suffered from post-COVID dilated cardiomyopathy or myocarditis, except for those, most of the patients which even we cardiologists are seeing are mostly probably anxiety related. Many patients say even 2, 3, 4 months after COVID, suffering from COVID, they come back with chest pain, with sweating, with palpitation, with ghabrahat. Most of them, I find that they are not suffering from any cardiovascular disease. Most of them don't have even significant fibrosis on repeat CT. It's mainly probably the psychological part of the syndrome, post-COVID syndrome, which is troubling them most. And I don't have any data to support that, but definitely I suppose yoga or relaxation and exercise, general exercise and reassurance helps them definitely. And of course, those who have a really post-COVID cardiomyopathy, they need specific treatment. And as Dr. Praveen very rightly said, assessment by D-dimer and anticoagulation, or addition of a statin or aspirin sometimes can help.
All right, sir. Perfect, sir. So thank you so much for this talk, sir. And now I will. Yeah, we have it with Dr. Madhusudan, sir. He's traveling, by the way.
One question from Parveer, sir.
Yes, sir. Tell me, please.
Our youngster orthopedic surgeons are facing a lot of financial problem. They are struggling day by day, going to the medical college, going to his clinic. So there are a lot of stress and strain. How they will prevent the cardiac problem? How will save his heart, his or their hearts from these problems? Later on, they may be suffer from.
I agree. Very pertinent question, sir. In fact, we are seeing that say the NEET PG is delayed by almost 7, 8, 9 months, and postgraduates are suffering because of that. And of course, those who have qualified and become a specialist, as you said, that I mean, they have started it and they have got a lot of work to do. They have got financial obligations. But I think probably one very important thing is to make them explain, and probably this should be done by seniors like you or Dr. Saraf sir, who are so much of experience, who have got so much of experience, and who have come through all those struggle that today what they have not become in one day. It's years of struggle, hardship that they have faced. And so if they expect that they can become like them in maybe months or 1 or 2 years, it's not possible. So they must have patience. Patience, of course, we realize that 25 years back or 50 years back, we didn't have so much of distractions. like mobiles, foreign travel, and this and that. Now there are a lot of distractions, which everybody wants a part of the cake, but you can't get it all in one go. So wait and watch, do your effort, maintain your health, try to be realistic, try to understand that everything takes time, take proper good nutritious diet, do exercise, do yoga, and take things easy. And you must labor hard, but don't be, just run after money. That is probably one thing which should be taught by all of us seniors to younger trainees, so that they have a very bright future ahead.
Thank you.
Very well said, sir. Very well said.
Thank you, sir. Excellent, sir. Thank you.
Yeah, health is one thing that which need to be taken care all throughout career. You can sometime it can go down, and anytime you can work hard and you can uplift your career. But health is one thing which will be constant throughout your life. So definitely
in this COVID time, I think age is no bar. We see day in, day out young people being affected by the disease. So we should take all the precautions, whether young or old. Everybody should take precautions.
Yes, sir. Thank you.
So now I invite Dr. Madhusudan to for Thanksgiving to Praveen Sinha sir.
Hello.
Yes, sir.
You are audible. Madhusudan, you are audible. Nothing to worry.
So I think he's traveling. I will do his part.
Shamsul will do his part. Shamsul will.
Okay, so I will conclude the session, sir. Thank you so much, Praveen sir, for joining us. Thank you from Bihar Orthopaedics Association. Thank you from Darbhanga Orthopaedics Association. It was indeed a marvelous talk. We learned a lot, and thank you for joining us. With this, we will end the session, sir.
Thank you. Thank you so much.
Thank you.
Thank you.
Good night, sir.
Good night. Good night. Bye-bye. Good night. Good night. Good night.